Look at this progression. If we do not take care of obesity in the early stages, if it goes unchecked, there will be a progression of liver damage. The normal liver will be converted into a seat of fat deposit, and that is what is called non-alcoholic fatty liver disease. What are the factors which govern or which control a normal liver becoming a fatty liver? Then, if we don't recognize even at that stage, this will progress on to non-alcoholic steatohepatitis with inflammation and some amount of fibrosis. What are the factors which convert NAFLD into NASH or NASH? This will be the point of discussion in the subsequent slides. If the patient is not identified even at that stage, remember these two are coronary risk factors, and if they are not identified at these two stages, majority of them progress on to cirrhosis, what is called the cryptogenic cirrhosis. In the earlier days, it was thought adipose tissue is only a fat depot, where the excess energy in the form of sugars and fats is converted into adipose tissue and stored as fats in the adipose tissue. It is no longer the view today. Each adipocyte in the adipose tissue is an endocrine organ. It secretes several vasokines, several endocrine substances, several vasoactive substances. These vasoactive substances cause inflammation wherever possible, in the vascular endothelium, in the kidney, in the myocardium, in the liver, and of course wherever there is endothelial cell, there will be precipitation of inflammation. And these adipocyte related factors will lead to insulin resistance. Once the insulin resistance is established, the liver damage will progress on to steatosis or fat deposition in the liver or fatty liver, and this is called the non-alcoholic fatty liver disease. In order to explain the onset of NAFLD and NASH, a hypothesis has been put forward, and this concept is called two-hit hypothesis or two-hit concept. The first hit on the liver is lipid accumulation. This lipid accumulation for a period of time, if it is left unchecked, it will lead to oxidative stress on the fat cells, on the fat laden liver cells, and there will be cytokine activation from the adipose tissue and from within the liver cells which are fatty, and that is called the second hit. So, it is a two-stage process, the first hit causing NAFLD and the second hit converting NAFLD into NASH or NASH. This slide further illustrates the two-hit concept. In the diet, supposing we take more of saturated fats, more of fatty food, and more of free fatty acids are available, they enter the liver and cause fatty liver. Normally, the fats that we take are burnt into end products like carbon dioxide and water, or they are converted into VLDL and triglycerides and stored. But if the excess of fatty acids and fats is presented to the liver, this mechanism of fatty acid oxidation, also called the beta oxidation, will be not sufficient to meet with the demand, so much so fatty liver will develop, or this is called steatosis. Steatosis or fatty liver, NAFLD. If the amount of saturated fat is much more than the unsaturated fat in the diet, fatty liver can result. This imbalance in the fats that we take can further damage the liver due to second hit. The second hit here is the oxidative stress thrown on the liver, on the fat laden liver cells, and the toxins that are generated and the inflammatory molecules that are secreted, all of them together act on the susceptible liver, the fatty liver, and convert it into a damaged liver or the NASH liver, non-alcoholic steatohepatitis. If this is left unchecked, liver cell death occurs and apoptosis or liver cell failure and death occurs, which will result in replacement of the liver tissue by fibrosis, and which is the end result as cirrhosis of liver. Let us understand that these, like normal liver, the NAFLD, the NASH, and the progression to cirrhosis are different diseases. They are one and the same. These are a continuum. So, the normal liver, when the fat accumulation is more than 5% of the weight of the liver, normal liver weighs around 1200 to 1400 grams. If the amount of fat in the liver is more than 5%, then NAFLD sets in, and that is the first hit. Deposition of fat in the liver, steatosis, also called NAFLD. Remember, this NAFLD broods insulin resistance and metabolic syndrome and further augments the risk for cardiovascular disease. This is one aspect of the fatty liver. The other thing is the NAFLD, due to the process of inflammatory reactions in the liver, the fat laden cells will progress on to NASH, and this is the second hit. And again, insulin resistance and metabolic syndrome play a very vital role in converting NAFLD into NASH. This NASH is a stage wherein still we can reverse the patient to normal. But if we leave this patient unchecked, there will be scarring and replacement of the liver tissue by fibrosis, hepatocyte apoptosis occurs, and that leads to decompensated liver disease or DCLD, also called cirrhosis of liver. Again, to reiterate the point that these are a continuum and we can interfere as early as possible in this chain of events. The scattergram here in this slide illustrates the relationship between the amount of saturated lipids that are deposited in the liver and the extent of liver cell injury. Liver injury or liver cell injury or hepatocyte injury is measured by the SGPT or alanine aminotransferase, also known as ALT, and this is also called SGPT in our common parlance. So, normally the SGPT value should be around 35. If the saturated fat in the liver is less than 30 grams per 100 grams of liver, then of course there is not much of elevation of liver enzyme. But as the amount of saturated fat increases from 30 to 40, 40 to 50 and 50 to 60, see, look here, the elevation in the liver enzymes even up to as much as 300 ALT or SGPT will be as much as 300. So, this is a summary representation of the relationship of saturated fats to liver injury. So, what is the natural history of a patient who developed fatty liver? Is it that everyone will progress to end stage liver disease and chronic liver disease and cirrhosis? No. Simple steatosis or fat deposition of more than 5%, it has got a very benign course. It has nothing to be worried about, but we have to recognize them and see that they do not progress on to the second stage. Only 3% of these patients develop cirrhosis. So, this is to highlight the fact this is the stage of prevention or early detection wherein we can institute measures to counter the insulin resistance, reduce the obesity, reduce the dyslipidemia, control the diabetes, and prevent the progression to the next stage. The next stage is NASH, NASH. There will be ballooning of the liver cells, there will be inflammation, inflammatory molecules trigger fibrosis to some extent, and this carries a worse prognosis. 30% of these people develop cirrhosis. Even at this stage, we can intervene and prevent further damage to the liver and bring them back to the earlier stages or normalcy. Remember, these two are also the forerunners for CV risk. Supposing the patient is not identified and checked even at this stage, then he progresses on to what is called severe NASH with fibrosis. 75% of these patients go in for cirrhosis. The 5-year survival is only around 67%. That means 1/3 of them are going to die in the next 5 years, and then more than half of them are going to die in the next 10 years. Such is the grave nature of severe NASH with fibrosis resulting in cryptogenic cirrhosis. So thus, it's important for us to understand the natural history and try and identify people in the stage of NAFLD or steatosis, that is this stage, and also at the stage of NASH, and prevent the progression to the cirrhotic stage.